Hello everyone, I am Subhojit Halder, a second year MD student. Today I am going to show the physical examination of the abdomen area. First we will proceed with the inspection, then auscultation, then percussion and then palpation. And I will also show the examination of the liver, spleen for splenomegaly and also the examination of the kidney. Then later I will proceed with some special technique for examining the possible ascites or possible appendicitis and also for the possible chances of ventral hernia. Hi, I'm Sholi Halder and your name and age please.
Dipesh, 23 years old.
Do you have any abdominal pain
No.
or difficulty in swallowing?
No.
Okay, so we'll proceed with the abdomen examination.
Sure.
Is that okay with you?
Yeah.
Can you change your gown and lie down please so I can proceed with the examination?
Sure.
Okay.
With patient health history in mind and with proper hand sanitization, we will proceed with the examination. To expose the abdomen, place the drip or sheet at the level of symphysis pubis, then raise the gown to below the nipple line just above the xiphoid process. Make the patient comfortable in a supine position with a pillow under the head or perhaps under the knees. Ask the patient to keep the arms at the sides or folded across the chest. Before you begin, ask the patient to point to any areas of pain so that you can examine that areas last. Warm your hands and stethoscope. To warm your hands, rub them together or place them under hot water. Approach the patient calmly and avoid quick, unexpected movements. Stand patient right side and proceed with a systemic fashion with inspection, auscultation, percussion, and palpation. The patient should have an empty bladder. Before proceeding with the abdominal examination, we should know about the abdominal quadrants. For descriptive purposes, the abdomen is often divided by imaginary lines crossing at the umbilicus and forming the right upper, right lower, left upper, and left lower quadrants. Another system divides the abdomen into 9 sections. Here in the picture, E denotes epigastric, U denotes umbilical, and H denotes hypogastric or suprapubic area. For the inspection, first observe the general appearance of the patient, lying quietly, breathing with discomfort, or gripping on one side. From the right side of the bed, inspect the surface, contours, and movements of the abdomen. Note especially skin temperature, color, scars or stria or dilated veins. Or also look for rashes or ecchymosis. Look at the umbilicus, observe its contour and location and any inflammation or any bulges or suggesting a ventral hernia. Then look for the contour of the abdomen. Is it flat, rounded, protuberant or scaphoid? Do the flanks bulge or is there any local bulges? Is the abdomen symmetric or asymmetric? Are there any visible organs or masses? An enlarged liver or spleen may descend below the ribcage. Look for the peristalsis at the abdomen for several minutes and also observe for the aortic pulsation which is frequently visible at the epigastrium of the abdomen.
Now we will proceed with the auscultation over the abdominal area. We will do auscultation before the percussion or the palpation because the different maneuver will interact with the auscultating sound.
Before auscultating, warm your hands and stethoscope. To warm your hands, rub them together or place under hot water. First, we will auscultate over the 4 abdominal quadrants. Learn to identify the variation in normal bowel sounds. Normal sounds consist of clicks and gurgles, occurring at an estimated frequency of 5 to 34 per minute. You may also hear prolonged gurgles of hyperperistalsis from stomach growling because bowel sounds are widely transmitted through the abdomen.
Now we will auscultate for the great vessel over the abdominal area. We will try to find is there any presence of bruit or any change sound.
Now we are auscultating over the abdominal aorta. Then we will auscultate over the both renal artery. Then we will auscultate over the both iliac arteries. Then we'll also auscultate separately over the liver and spleen for frictional rubs.
So there is no presence of abdominal bruit or the friction rubs.
Now we'll percuss over the abdominal quadrants. Percussion helps us to assess the amount of distribution of gas in the abdomen. We will here determine the distribution of tympani and dullness. Tympani usually suggests the hollow area over the abdominal surface. It usually suggests the area is occupied by gas, and the dullness which suggests the presence of fluids or abdominal mass or organs.
Now we will proceed with the palpation. First, I will palpate lightly over the abdominal quadrants, and I will ask the patient if he feels any pain or not. And also, I will observe the patient's facial expression for any discomfort during the palpation. So let's proceed. Tell me if you feel any pain, okay?
No. No. No.
Okay. We'll proceed with the deep palpation.
Deep palpation usually helps
quadrants.
us to assess the possible
Tell me if you
peritonitis.
feel any pain.
There
okay?
are three signs of peritonitis. One, carding, which is a voluntary contraction. Rigidity, it is an involuntary reflex. And rebound tenderness refers to pain expressed by the patient after examiner passes down on the area of tenderness or suddenly removes the hand.
Now we'll proceed with the examination of the liver. For the examination of the liver, first we will do percussion. I will percuss along the mid-clavicular line. First, I'll start from the right lower quadrant for finding the lower border of the liver, and then along the mid-clavicular line from the nipple line, I will find the upper border of the liver. Then I will measure the diameter of the first and second point, and we'll find.
Now starting percussion at a level well below the umbilicus in right lower quadrant. Next, identify the upper border of liver dullness starting at the nipple line. Percuss downward in the mid-clavicular line until the lung resonance shift to the liver dullness. Then use a centimeter scale to measure the 2 points of dullness. Here I got the diameter is 7 centimeter, which falls in normal range along the mid-clavicular line.
Now we will do palpation. Take a deep breath, please.
For percussion on the liver, place your left hand behind the patient parallel to and supporting right 11 and 12 ribs, adjacent soft tissues below. Remind the patient to relax on your hand. Now ask the patient to take deep breath, then palpate in steps toward the costal margin.
Take a deep breath, please.
We can also palpate the lower
Breathe
part
out
of the
now.
liver by hooking technique. Press in with your finger and up
Again
toward the
deep breath.
costal margin and ask the patient to
Breathe out
take
now.
a deep breath.
Okay.
For a non-palpable liver, we will assess the percussion tenderness and ask the patient to compare the sensation.
Next, we'll examine the spleen. First, we will proceed with the percussion for checking the splenomegaly. There is two techniques for the percussion of the splenomegaly. First,
For the first technique, percuss the left lower anterior chest wall roughly from the border of the cardiac dullness at the sixth rib to the anterior axillary line and down to the costal margin, an area that is termed as Straub's space. Next, check for splenic percussion sign. Percuss the lower interspace in the left anterior axillary line. This area is usually tympanic.
now we'll do the palpation for the splenomegaly.
With your right hand below the left costal margin and ask the patient to take a deep breath and press in toward the spleen to feel the tip or edge of the spleen as it comes down to your fingertips.
Okay. Can you move this side, please?
Now,
Okay.
repeat with the patient lying on the right side with
Take a deep
legs
breath.
somewhat flexed at the hips and knees.
Breathe
In
out.
this position, gravity may bring the spleen forward and to the right into a palpable location.
Second.
Now, edge of the enlarged spleen palpable about
Breathe out
2
now.
cm below the left costal margin on deep inspiration.
Now we'll examine the kidney. Usually right kidney is lower than the left kidney and it is more palpable than the left kidney. So we'll proceed with the right kidney palpation and we have to do the similar palpation technique over the left kidney also. So let's proceed.
Now, move to the patient's right side. Place your left hand behind the patient, just below and parallel to the 12th rib, with your fingertips just reaching the costovertebral angle. Lift and trying to displace the kidney anteriorly. Place your right hand gently in the right upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, place your right hand firmly and deeply into the right upper quadrant, just below the costal margin.
Tell me if you feel any pain, okay?
If the kidneys are tender to palpation, assess percussion tenderness over the costovertebral angles on both sides and compare the sensation.
Now? Okay.
Press firmly deep in the epigastrium, slightly to the left of the midline, and identify the aortic pulsation. Now, assess the width of the aorta by pressing deeply in upper abdomen with one hand on each side of the aorta. A normal aorta is not more than 3 cm wide.
Now we'll proceed with some special technique for different abdominal abnormality. First, we'll assess for the possible ascites over the abdominal area.
A protuberant abdomen with bulging flanks is suspicious for ascites, the most common complication of cirrhosis, because ascitic fluid usually sinks with gravity, whereas gas-filled loops, bowel, rise. Dullness appears in the dependent areas of the abdomen. Percuss for dullness outward in several directions. From the central area of tympani, map the border between the tympani and the dullness.
Okay, so there is additional two technique for confirming the ascites, possible ascites. First, we'll test for the shifting dullness, and then we'll test for the fluid wave.
In a person without ascites, the border between tympani and dullness usually stays relatively constant.
Okay. Now we'll proceed for the test of fluid wave. Can you put your hand like this? And this? Okay.
While you tap on flank sharply, your fingertips feel on the opposite flank for an impulse transmitted through the fluid. Here it is negative, so there is no ascites.
Now we'll assess for the possible appendicitis. First, I will palpate over the McBurney area for any tenderness. Then I will examine for 3 different techniques or the 3 different signs that will help us to indicate if there are any appendicitis or not, positive or negative. So let's proceed. Now we'll look for the McBurney tenderness. Tell me if you feel any pain, okay?
Here no tenderness found over the McBurney's area. Next. First we'll palpate for the positive Robson sign and that is referred rebound tenderness. Press deeply and evenly in the left lower quadrant, then quickly withdraw your fingers. If the patient feels pain in the right lower quadrant, that indicates the positive Robson sign for appendicitis. Then assess for the psoas sign. Place your hand just above the patient's right knee and ask the patient to raise the thigh against your hand. If the patient feels increased abdominal pain on the right lower quadrant, that indicates the positive psoas sign for appendicitis. Next, we'll assess for the obturator sign. Flex the patient's right thigh at the hip with the knee bend and rotate the leg internally at the hip. This maneuver stretches the internal obturator muscle. If the patient feels pain in the right hypogastric area, that is the positive obturator sign for appendicitis. Here, the patient feels none, so there is no presence of appendicitis.
Now we will assess for the ventral hernia. Can you raise your head and shoulder together, please? Okay, now rest. Okay, there is no presence of ventral hernia. So that's it for the physical examination of the abdomen area. Hope you enjoyed it. Thank you for watching.